All right, so my topic, just like Toby said, is prevention of workplace violence among nurses in Northeastern Ontario. Judy Horrigan is my supervisor, and co-authors are Roberto Hill and Amy Donato. So a quick overview of my presentation. So definition of workplace violence, I'm talking about definition of workplace violence, introduction on what this is all about, talk about the violence assessment tool, a quick review of the literature, and research rationale and research questions, a framework guiding the study, my methods, strength, limitation, and finally a conclusion. So definition of what workplace violence is. So workplace violence, according to the Occupational Health and Safety Act, is described as either exercising or an attempt to exercise physical force by a person against a worker in a place. Or this can also be seen as an act that is perceived as a threat to the staff. So workplace violence can also be physical, and by physical, like acts of biting, hitting, can also be sexual, any unwanted behavior that is seen as uncomfortable, sexual behaviors perceived by the staff, can be seen as psychological, so bullying, threats, financial, any behavior that prevents promotion of the staff, and it can also be seen as horizontal or vertical. So by horizontal, violence on the same level of hierarchy, on the same level of staff, and then vertical is based on seniority or vice versa on the same level of on different hierarchy. So the Occupational Health and Safety Association also classified workplace violence as 4 different types. So type 1, or external perpetrator. Here the person inflicting the violence is either a visitor or not related to the workplace. And type 2 is the client or customer. Here the person is related to the workplace, so like the patient in this scenario. Then type 3 is employment related. Then type 4 is domestic violence. So by employment related, I mean among workers. So for the sake of this study, I'll be concentrating majorly on type 1 and type 2. So workplace violence is increasing. Irrespective of all what we have available of preventing workplace violence, it still seems to be increasing. It's identified as a major occupational hazard globally, hence we need to act and find out ways in which to further reduce this. 50% of female nurses experience this more than male nurses, and this can be attributed to the fact that females dominate this profession. Then violence in hospitals among registered nurses has caused 50% of lost time injuries. So there's a need to actually try to reduce this. 8% of a study done by QP, a poll rather done by QP, Canadian Union of Public Employees in 2019 showed that on North Ontario Eastern nurses experienced violence 8% higher than the entire province at large. So workplace violence is a problem across health sectors, and this affects healthcare delivery. So we need to act. So consequences of workplace violence include, but not limited to, poor recruitment and retention of staff, staff exhaustion, anger and depression, anxiety, disruption of sleep, physical injuries, post-traumatic disorders, somatic disorders, fear, and feelings of revenge. So I'll be talking about the VAT since my study is related to the VAT. So the Public Services Health and Safety Association created a violence assessment tool to predict the possible risk of violence from patients in acute care settings. And they developed this from a literature search. So they compared 2 different checklists, so the Brocet violence checklist and dynamic appraisal of aggression instrument. And in comparing both of these checklists, they found out that the VAT was an improvement of the 2 and had some certain indicators that the others do not have. And I'm going to be showing you a little bit about it here. So here, the very first, the VAT tool has 3 sections. So we have section A, where we have the risk indicators with a particular score. So 1 score attached to each complaint or each behavior, observed behavior. Then this is a full screen of that. So you have different all of these, then confused, irritable, all these behaviors. Then under it, according to the score, is given actions to take. So according to the score, for example, if you look at the score of 0, an action to take for that to continue to monitor and remain alert for any potential increased risk and communicate any change in behaviors. That is also seen there. Then the 3rd section is contributing factors. So factors that are seen that can prevent this workplace violence even before they occur. So some physical factors that you see in the patient, that when you act with this can also prevent this before they happen, psychological and environmental, and also some activities that can also lead to workplace violence. So we also have, these are all potential de-escalation techniques that can help to reduce workplace violence. So the violence assessment was mandated to be used by the Ministry of Health in Ontario. And this study will actually be the first study to examine nurses' perception of the VAT in Ontario. So my study, implications of this study is going to help in addressing gaps and enhancing the use of the VAT in Ontario and Canada in general. So the study of the perception of the use of the VAT is necessary considering the impact of workplace violence has on healthcare workers and on the health system as a whole. So this would lead to better outcomes for nurses and for patients. So a quick review of my literature. So I looked at this under 3 different sections. Okay, so the first is dimensions and characteristics of workplace violence. So like I said, type 1 and type 2, a major issue of concern, and we're seeing the emergency departments, psychiatry departments, and other health units. There was also underreporting of violence, the lack of policy for reporting. Many of them viewed this as part of their jobs, which is not supposed to be so. Still under dimensions and characteristics of workplace violence, many of the staff and even patients justify their reasons for giving aggression or inflicting violence towards nurses. There's also dissatisfaction in their jobs. Consequences of violence in workers, like I said in previous slides, include anxiety, anger, and a host of the others, but I'm not going to mention them again. Then the next section of the review found out that a list of available tools that have been used to reduce violence. So there was evidence-based intervention, education and availability of education and training programs, diversion and de-escalation techniques, and zero tolerance policies. Still on this, we also have simplified reporting systems, and a study done by Canadian authors actually showed that there was a need to develop a violence assessment tool that will be predictive of violence. And study done by a US author, when they implemented some of all these interventions, they actually found out there was an improvement in that facility. The third section is the post-incident support process. So we need to make this available to support staff after they've actually experienced violence. So no studies have been done on the VAT in Northern Ontario, and also remote northern communities were not studied in the literature. So this study could potentially reduce violence and reduce the rise in healthcare costs among the different healthcare sectors. So this brings me to my research questions. The first one is, what are Northern Eastern Ontario nurses' perceptions of the VAT in assessing the potential risk of violence in acute care settings? Any gaps or challenges or improvements that need to be included in the use of the VAT? And a quick summary of my framework. So this was adapted from the Public Health and Prevention of Diseases. So we have the host, the agent, and the environment. So in this case, for the host, the violence sufferer, the nurse. Then the agent is the person who's inflicting the violence. The environment here is the situation where it's happening, in my case, acute care settings, so like a hospital. And this framework also has another section attached to it, like you have different classification of what happens before the assault, during the assault, and after the assault, and a list of interventions that can be taken at each of these stages to be able to prevent the violence. A quick review of my methods and design. So this is part of a larger study. So the first phase includes a chart review. So we're going to be reviewing patients' charts that have been discharged on their instances of violence and how the tool was used or was reported on the tool. Then the second phase, which is going to include focus group sessions, is going to be via Zoom, obviously because of the present COVID-19 situation. And we're looking at 6 to 8 nurses from each of the medical units, each of these following units: medical unit, the mental health unit, and the emergency department. We chose these units because these are units where violence is said to occur most frequently. And in total, we're expecting 18 to 24 participants. So the way it's going to work is a video is going to be shown to the patient, to the staff, where a violent incident was demonstrated, and they'll be given the tool to assess it. Then this will lead to discussion. And at the end of the day, we'll be analyzing the data by Saliton's methods to see, which involves lots of processes of analyzing, writing, and putting together our results to see what we arrive at. So, study strength, use of an interpretive descriptive approach. I'm going to explain this further. So usually what we know about is a description, a qualitative descriptive approach. But here we're adding an interpretive to it. So not only are we just describing, they're also going to be interpreting the experiences so far, and their idea on the use of the tool. Then the fact that the study is going to be carried out in a northern community is also an advantage. And then some limitations. of this study include the use of just one hospital in Northeastern Ontario and the possibility of a bias. I'm going to explain this further. So for selection, because we're using nurses and non-response bias, they might be so busy in their schedule of work, especially now with the COVID-19 situation, and so might have issues with that. But obviously, because we're going to be using Zoom and it's going to be done outside their working hours, we hope to conquer that setback. So progress on the research so far. So data collection is expected to begin soon once the lockdown of 4 weeks ends. Then we're going to proceed to writing findings, and at the end of the day, in conclusion, we'll hope to find out what their perception is about this tool and how it can be changed and how it can reduce workplace violence, and also how we can implement this in the whole of Ontario and, if possible, the whole of Canada in general. These are my references. And I also want to thank CROSH for also one of the huge sponsors of this research. And particular questions. Thank you. So, and thank my supervisor, Judy Horrigan, and also my community members, co-authors. And we need to take questions now. Thank you.
Oh, thank you very much for sharing this. Yeah, I think this is very important research. And yeah, this is really insightful. I know I've learned a lot just from your presentation. So thank you. Now we do have some questions coming in. And so you indicated that 50% more female nurses experience violence than males, contribute to a larger number of female nurses. Oops, sorry, let me just make sure. Actually, Fego, can you see this in the chat? It's a longer question, it just might be easier for you to see.
Workplace violence was the #1 hazard in the 2015 risk assessment. Is that the question? Is that the question you're referring to? Toby?
Yes, yeah.
Oh, okay.
Well, here, we'll come back to that one. Okay, so we'll skip that one, come back to another one. So workplace violence was the #1 hazard in a 2015 risk assessment done for hospitals facilitated by the Ministry of Labor, Training, Skills Development. And so there's been some good work done in response to that. So have you read that report yet? Oh, you have. Fantastic.
Yes,
okay, because Joy has offered to share. Okay, so fantastic.